Welcome again to Professor Emmanuel. Thank you. You're already there on the earlier conference, and patients were really so happy that somebody with more knowledge about these problems, the GI involvement in Duchenne, presented then. So everybody's looking forward to this presentation as well, as it's a life-threatening situation sometimes, and if it's not life-threatening, then at least it creates a lot of discomfort for patients. So thank you again. The floor is yours. Thank you.
Thank you, and please accept my apologies for not working in the correct time zone. So thanks for being flexible. So this is really a pleasure to be able to join, because I think the role for someone with my specialism is to provide one part of care for the complex needs of patients with neuromuscular disorders. And the gut problems, I think, are ones which are very, very common, but they're often not regarded as being necessarily very serious until the very end, i.e. nutritional problems. And other ones are regarded as, well, it's part of, something to expect. Whereas doctors historically have not necessarily been as proactive, it's also true that for most patients, it's really a big part of their life, because it's these often are the very personal, embarrassing things with bowels, or the social interaction things around meals. So I think that, from my point of view, the involvement and importance of this work is to try and improve quality of life and work with patients on the things that really harm their quality of life. So the thing about this also is then to explain that the gut is something which begins at the mouth and ends at the bottom. So it's one long continuous tube, between 6 to 8 meters long, depending on factors, but basically one long tube, which is not just a tube. It has special adaptations. Some parts of it like a tank, like the stomach or the rectum. Some parts just like a conveyor belt, like the small intestine. Some parts like a motorway, like the gullet, which moves very fast. But all of that mechanism is coordinated by a set of muscles around the tube. So it's a specialist tube with muscles on the outside, which goes at different rates and has different functions to absorb or to digest or to store things, but ultimately to propel things, and has that twin function of absorbing nutrients from the food you eat and the water you drink, and then getting rid of the waste that you can't get rid of by either breathing out or passing urine. So it's both an intake as well as an output system through a muscular tube. And one of the things that's very obvious is for children and adults with neuromuscular diseases, the muscle of that tube can get involved in the same way as the muscle of the body. And so you end up with this situation where different symptoms can occur. And I put this very, very busy slide on for one reason, which is that we worked as a multidisciplinary group a few years ago to produce a thing to help professional colleagues. So this is not intended for patients, it's to help colleagues. And looking at identifying the symptoms that occur in patients with neuromuscular disease. And in pale colors at the top there are the upper gut symptoms, and the sort of small intestinal symptoms in the middle, and then the colonic symptoms. And the point I wanted to make was, and the idea was that you went through the narrative of this thing we produced was to talk about how you assess, what are the things that are causing it, how you intervene through nutrition, and how you intervene through medication. But what I wanted to highlight is the thing in the red box there, which is that for all patients, for all of these presentations, always think about constipation first, because constipation may present as constipation, but it often may present as discomfort or bloating. It can even present as heartburn and difficulty with meals. So it's a really more complicated story than it appears, that constipation may actually be the underlying mechanism for these other problems. So what is the point with all this? The thing, if we begin at the top of the system, and I won't tread on what Jody will present much more elegantly shortly, is to think about, as a clinician, what are the things that should make us trigger involvement of the wider team? And of course, things like weight loss is one aspect, with all the caveats that measuring weight can be very difficult for some of the patients that we have. But even the subtler things, meal times taking longer because it's harder to swallow safely, or because tiredness, excessive drooling, which you maybe think, oh, well, it's just a one-off, but which happens a bit more. Waking up after lying flat with a wet voice. Things like, say, weight loss and pneumonia, those are much more obvious things, but there's the more subtle things that I think we're keen on. And again, I wanted to tread on Jodie's toes. Remember that we have a very complex system in terms of swallowing we're dealing with. And the aim of this, and I said I will leave what Jodie and her team and colleagues like her do around the world, but to mostly talk about when we identify this, it's about trying to provide nutritional support. And nutritional support should always, where possible, begin by using the gut, which is the best way of getting nutrition into oneself. Ideally through food, but if not, then through a tube, and only to rely on intravenous feeding as a very, very last resort. So what's very clear is that neuromuscular patients, especially in more advanced complex disease, will often progress to needing support with nutrition. You can see that by the time patients are needing help with ventilation, a third of those patients are often also experiencing nutritional problems, partly from the underlying disease, but partly also from the needs that occur with having such restricted calorie intake. Yet that happens, that malnutrition is seen in a third of patients, but only half of those have a low weight. So I say weight is not something that you necessarily can rely on as an early feature. It's very much a late feature. So don't rely just on weight. Think of the other symptoms I mentioned. And then for patients with more mild symptoms, there's also this issue that eating food causes these symptoms like loss of weight, or more importantly, loss of appetite, And people talk about having food intolerances. What that is caused by is that the muscle of the stomach isn't doing its job. So the stomach is normally a small shrunken organ. And when you eat, it gradually stretches. So when you wake up in the morning after an overnight fast, it's small as the size of your fist. But as you eat, it gradually gets bigger. The muscle relaxes. And that muscle relaxation is an active process. It needs the muscles to actively function. It isn't just like passively stretching it. And so muscle diseases, that relaxation may fail. So you get what they call a failure to accommodate or failure to relax the stomach. And so patients will feel full with only eating a small portion, because if your stomach doesn't relax, you feel full with only a small bit inside it. And so in general, in those situations, it's fair to say that things which stretch the stomach less and cause less digestive energy to be needed, like reduced fiber, reduced fat intake, are things that are generally more tolerable. Now, I just want to go through a few of the highlights of things to try and give some practical things that are takeaways. And abdominal bloating is another thing that we get patients complaining of a lot. And of course, again, people tend to say, oh, well, it's to do with posture in the chair, and those things undoubtedly contribute. And loss of abdominal wall tone, which means that the internal organs are now pushing against a soft abdominal wall, which pushes out. And so that causes some of the bloating. But it's also true from our data that bloating can occur as part of something called small intestinal bacterial overgrowth. Because normally the small intestine, when it's healthy, doesn't have too many bacteria. But when the gut doesn't move normally, because the muscular tube, as I keep saying, doesn't work normally, then those small number of bacteria, instead of getting brushed away, can stay there and thrive. And then they start eating your food instead of your body consuming it. These bugs can start consuming it. And because the treatment for this is very effective and to use very specific antibiotics, but we obviously don't want, to be giving antibiotics too easily. So we often test, and there's a very simple breath test, it's called, to identify whether the patient has bacterial overgrowth, where you give some glucose, and if the bacteria are present, you get this little rise in hydrogen or methane that we can measure. And if you see a curve which increases like it does on that little graph there, then we know this is a positive test. Why am I telling you all this? I'm telling you all this because if a patient presents with bloating, which is more than just to do with body shape or changes in weight, it's important to think about bacterial overgrowth. And rather than just giving antibiotics blindly, because they may have problems by just giving antibiotics blindly, it's rather better to have a test to know whether this is an overgrowth problem. But I said I wanted to spend a lot of time, or most of my time, if that's okay, talking about constipation. And constipation is a rather complicated thing. In fact, to have a bowel which works, it's not that straightforward. And a bit like swallowing, as I said earlier on, it's complicated. Your bowel is also complicated. And the analogy I often use, any of you are patients that I've had a chance to contribute to your care, you've often heard me say this. I talk about getting your bowel to work like getting toothpaste from a tube. First of all, the rectum has to be full. It's no point trying to squeeze toothpaste from an empty tube, number one. Secondly, you have to know it's full. So you need to have the sensation from your rectum to tell you, your brain, that it's full. So if you have an empty tube and you don't know it, that's one thing. If you have a full tube but you don't know it's full, that's another thing. So you've got to both have the stools in the right place, i.e. in the rectum at the bottom. Your brain has to know that it's full. You then have to be able to squeeze it, because again, part of going to the toilet is squeezing your abdomen, but it's squeezing selectively one part, not just putting your whole body and your neck and your throat and everything under strain. That isn't effective squeezing. So we can sometimes help train patients, because sometimes, again, it only sounds silly that we all think we know how to go to the bathroom, but we don't necessarily. If things have become more complicated, it can become quite difficult to squeeze the tube, as it were, and know how to selectively apply pressure. So we sometimes offer biofeedback to help patients get orientated about how to use abdominal muscles and diaphragm to help them evacuate more effectively. Then you've got to be able to relax your bottom end. So by taking the lid off the toothpaste tube, you've got to be able to relax the anal sphincters, sorry about this, so that things come out. So there's no point just squeezing the tube. If the lid is on, you don't get any toothpaste out. You've got to squeeze it and take the lid off, by which I mean brace the abdomen in the right way, but also relax the sphincters. That's taking the lid off. And then you've got to get the stools in the right consistency. If the stools are too hard or equally too loose, they won't necessarily come out. So there's quite a few things that we can work on with patients. So when we talk about patients with constipation, we're assessing a number of things. If you think people like me are asking a lot of very personal questions, it's to see which parts of this mechanism are wrong and see which ones we need to work with. And the point being that this is a slide for patients actually with spinal cord injury, but the treatments are very similar. Sorry about this. This slides keep jumping. But what I wanted to make the point with is that there's a number of things we can do which can allow us to improve function. And which of those parts of that mechanism I showed you, the toothpaste tube, is wrong, are what we need to really work on with the patients in each individual situation. So it's not that I can say to you, oh, well, just do stimulation, or just do massage, or just do suppositories. It isn't like that. It's tailoring the treatment we should be offering to the right patient. And what are the things that you as a patient or carer can do? In general, taking a fiber-rich diet doesn't help this kind of constipation for neuromuscular patients, because neuromuscular patients have a problem with slow transit through the system. As I said, the muscular tube isn't contracting. And if you increase fiber in that situation, you tend to make patients more bloated and more windy. The fiber just makes them more distended. It doesn't actually help them empty. Equally, physical activity doesn't really help. Number one, it's quite difficult for a lot of our patients, certainly as they get to more advanced disease, to be able to manage. But actually, physical activity on its own doesn't help. So the idea that you can blame oneself for thinking, oh, I'm not moving as much, therefore I'm more constipated, that doesn't hold true for this kind of constipation. Equally, taking more liquid doesn't help. You obviously need to take at least, 1.2 liters a day. But if you get chronic constipation with neuromuscular disease, it isn't a problem of not having enough water. Assuming you're drinking your 1 liter, taking lots of extra water, 2.5, 3 liters, there's no way of selectively holding that water in your bowel. You just end up peeing it out. So we tend to say to patients, if you want to consume liquid, take it up to that kind of at least 1.5 liters or so. But taking more than 2.5 liters a day to make your bowel work more often won't help you. What is important is to get to the correct position in the toilet, and to get into a routine of using your bowel after meals, in the morning, after a warm drink, to get into a pattern of that. Those things really make a big difference. And the right position is one where the knees are above the hips when you're sitting down. So not the kind of traditional throne position, like on the right-hand side of that incorrect image there, but so putting a little book or stool or something underneath your ankles so that your knees, when that happens, that really opens up the angles that are normally kept closed, that allow you to empty out properly. Now, Beyond those things for constipation, there are also a whole range of laxatives. There are laxatives which work by holding on to the liquid content in the stools. There are laxatives that work by coating the lining of the bowel. And there are laxatives that work on making the bowel muscles contract. These all work in a very non-specific kind of way. They have a very, what they call a generic action. They work by having contact between the drug and the bowel lining, shown as a cartoon in this cross-section. So the more time that these drugs in the dark blue on the right have contact with the bowel lining, the more of an effect they have. And those can be effective, but because they depend on contact, they can be unpredictable. And that's a big problem for a lot of our patients. Because, you know, if you think about it, what do you want? If you want to take a drug for a bowel, you want it to work when you want it to work, and you want it to stop working so you can get on with your day. You don't want to be taking something which may work 2 hours later, may work for 3 hours after that, may not work for, you know, you want to take it and be predictable. And the longer you take these drugs, for many patients, the less predictable they can become. So using it occasionally, that situation can be very successful. And what has emerged is there's some new drugs. So I don't want to necessarily go through the list for these things, but there are drugs which have very, very targeted approach. So rather than having that more generic approach, like I said, where they work on the bowel wall like laxatives, these drugs hit very particular receptors, like prucalopride, which is licensed in most European countries. If there's these drugs called the mu opioid receptor antagonists, which basically block those receptors, especially if patients are requiring opioid analgesia and can help with constipation. Drugs like lubiprostone, which work to activate a channel called the chloride channel, which increases water secretion into the gut. And drugs like enactidide, which activate that same chloride channel, but do it through an indirect mechanism to do the same thing. So there are a whole range of emerging therapies which can target much more specifically. And they're not better, but they're just an alternative way. So what I'm trying to persuade you of as patients and carers is that there's things that are emerging, and that as professionals, that there are a range of simple things which help, simple things which don't help, and there's no point putting a patient through, and then emerging therapies which can really be useful. And it's important to do this because, as I said earlier on the very first slide I showed you, if we get constipation management right, we will often improve things like reflux and heartburn and sense of how well somebody can tolerate a meal, abdominal bloating. But also another thing that happens a lot for patients, and Elizabeth and colleagues asked me to speak about a little bit, was hemorrhoids. And hemorrhoids, I would say to you one thing I say to all patients: every human being has hemorrhoids. Yeah, it's normal to have these internal structures. You can see on that left-hand picture here, this is like a cut through of the bowel with the anus as the opening there. And we all have this little tissue in blue there, little internal hemorrhoids. That's normal. And we have tiny little things, at the bottom there, at the external opening near where the anus is, which again are tiny little things. They don't usually protrude. But if we strain a lot, these internal tissues can become bigger, and you can get a bulge into the bowel. That bulge is a very soft, squishy bulge, so it never obstructs the bowel. So people sometimes think, oh, my hemorrhoids are blocking me going. They're not. They are very soft. They're like a little marshmallow. So the stool will easily push it aside. But it's the fact that they can sometimes then cause mucus leakage, or sometimes they can bleed, or if the patient is having to have help to assist stools out, sometimes the finger can catch on that and it can then bleed a bit more. And those are the internal hemorrhoids, but also this little external tissue that I said that we all have a bit of, that can get bigger from straining. So you can sort of see how if we strain, these little soft tissues, these little soft marshmallows can become bigger marshmallows. And so I've just put there the things that we can do to help. Over-the-counter hemorrhoid creams like Anusol or Proctosedil, which contain a little bit of numbing agent and a little bit of steroid, can be very useful if there's pain or leakage and bleeding, because the numbing agent also stops any bleeding. And the alternative is if you're able to, these little things called sitz baths. These are little basins which sit on top of the toilet, and you can put your bottom in there, and it just gives with warm water, and that warm water helps reduce the volume of these hemorrhoids if they're causing particular problems. So they're simple things, which mean that we very rarely need to go on to full surgical interpretation. So my last slide is the things which is, I guess, the call for help, which is what are the things we can do. We don't really fully know how often patients get complaints like this. We only know the patients who complain to us, and maybe there's many patients out there who we don't see. So I guess what I'm trying to say with that is let's try and be active case finders. If you're a healthcare professional, don't wait for patients to come and tell you, because they're often going to be embarrassed about piles or constipation. It's not something we like talking about. So we need to go out there and find these patients and try and help them with these simple things. Think about what the patient and carer wants in terms of, sometimes we don't want to give people complicated therapies. If they say, look, actually I can manage it, I just want to know whether it's safe or not safe. So give patients the therapy they need. There are very particular nutritional things about how best to address nutrition and how to best correct nutrition, specifically in patients with Duchenne's. Is there a way of tailoring the feed best? And then as we move into transition, the calorie needs as patients transition from adolescent care from childcare into adolescent into adult care. What is the dietary growing needs that we have there? And would early intervention there cause better health? So there are lots of nutritional and upper gut things that we can do and need to address better. Thank you very much for allowing me to share some of the thoughts around this. And as before, I'm always very happy if questions come up to answer them now, but if questions are sometimes embarrassing to ask and you want to email me, I'll put my email in the chat, and I'm very, very happy to pick those up one-to-one.